Hi, I'd like to thank you for the invitation to present. I would much prefer to have been in Chile, as I've never been, but hopefully this will be an avenue for me to come down and see everybody in person. But today I'm going to talk about the incidental gallbladder cancer and any role for neoadjuvant chemotherapy. An overview of the talk is I'll talk a bit about epidemiology, the general workup and treatment, and I'll stress the role for neoadjuvant chemotherapy in this setting of incidental gallbladder cancer and the role for surgery. I have to thank Gene for the invitation. He spent some amazing years at Memorial Sloan Kettering with us at this point years ago, and a lot of the data that I'll show today is data that he generated. And one of the studies was comparing patients we had in the US to Chilean patients and Japanese patients. And you can see there's really a similarity in the US and Chile, that 65, 68% of the patients with gallbladder cancer had incidental diagnosis, whereas in Japan it was much less, 19%. So clearly some regional differences around the world when looking at this problem of incidental gallbladder cancer, but some overlap in presentation percentages between the US and Chile. So how about the workup for patients with incidental gallbladder cancer? Well, first, it starts with a review of the pathology, especially the cystic duct, which is positive in up to 30% of incidental gallbladder cancer patients. And it's important to get information from the initial operation, things like was bile spilled, which would lead to a higher rate of peritoneal metastases, and what was the surgeon's general impression when they were in the operating room about what stage this was. Did they think they were cutting through tumor? Did they think that they left behind obvious lymph nodes? All pieces of information that can be helpful. Rechecking or checking for the first time a CA19-9 and CEA is helpful. Radiographic staging, and then determining timing of the reoperation. There have been some updates on gallbladder pathology, and this can be helpful from the pathology and imaging review from any scan that was done prior to the cholecystectomy. This was a retrospective multi-center study led by MD Anderson, looking at 437 patients on curative intent resections, where they looked at tumors on the peritoneal side versus on the hepatic parenchymal side. And there was an association with a difference in survival, with improved survival associations on peritoneal side of tumors compared to hepatic side tumors. And when they looked at T2, hepatic and peritoneal, there were significant differences in vascular invasion, neural invasion, micrometastases in the adjacent liver, and node positivity, all with peritoneal disease, the peritoneal side of gallbladder associated with improved outcomes. And this is something that can be determined either from a review of pathology or from preoperative imaging prior to the initial laparoscopic or open cholecystectomy. We've also looked at what the role for PET scan is in this setting. This is a study of 2001 to 2013 with 100 patients. 63 patients had incidental gallbladder cancer, and PET changed the management in 31% of primary gallbladder cancer patients, but only 13% of patients with incidental gallbladder cancer. It's really very difficult to interpret PET avidity in the surgical site. So in general, we don't use the exam in this setting, but instead favor just a high quality CT scan of the chest, usually a triphasic scan of the liver, and a contrast scan of the rest of the abdomen. Timing is also an important component of dealing with these patients. We have patients who come in a week after their laparoscopic cholecystectomy, and we have patients who come in 2 or 3 months later. And often it's unclear as to what took them so long to come in to see an HPB surgeon. This is a very interesting study done 10 years ago, where retrospectively they looked at 2003 to 2011. and they had 49 patients with incidental gallbladder cancer. 49% of the cholecystectomies were R1, and there was gallbladder disruption in 59% of the cases at initial operation. So clearly high risk. And the paradigm that they had followed was, after the diagnosis was made, they waited 3 months with no treatment, did a staging CT scan, and then decided OR versus no OR. When looking at the 49 patients, about half were re-resected. So brought to the operating room, no additional sites of disease found, and had liver and portal regional lymphadenectomy. But a significant number of the patients, 51%, were found to be inoperable at staging. And this was due to vascular involvement, peritoneal involvement, liver and peritoneal, lymph node metastases outside of the regional lymph nodes, hilar mass with liver metastases, and distant lymph nodes, and combination of liver and distant metastases. And the overall survival was 20.7 months for the overall group of patients, but 54.8 months for the re-resection group. And not surprisingly, those that had progressed in that 3-month time period had an overall survival of only 9.7 months. So this is an important study to sort of set up the idea of neoadjuvant chemotherapy for this group, because there was value in time and seeing biologically which patients were going to progress before bringing them back to the operating room and restaging them. And so I think there's a number of reasons that can be thought of as a rationale for neoadjuvant therapy in incidental gallbladder cancer. One is there is a significant risk of recurrence after resection. Another is chemotherapeutic agents with activity and some evidence of treatment efficacy do exist. And third, high-risk groups are identifiable. And these are sort of general principles of neoadjuvant chemotherapy and neoadjuvant approaches to most malignancies when these different points exist. Now, if you think of pancreas cancer, where there's been a growing shift towards neoadjuvant, gastric cancer, very big shift towards neoadjuvant, lung cancer. So in so many cancers, there's really been this shift towards neoadjuvant. I think gallbladder cancer is one of the later ones where this is being considered. So we do know that recurrence is frequent and it's often distant, and this is really a major cause of failure of surgery. So if you go back to that study in 2012 where they waited 3 months, half of those patients, if they had operated on them the day of the day that they made the pathologic diagnosis of gallbladder cancer, those patients, almost all of them, probably would have been progressing 3 months later. So the surgery wouldn't have been helpful. So when you look at recurrence, this is a study looking at recurrence in 65 patients, which was 56% of the group. Median disease-free survival was 26 months. Disease-specific survival, 42.8 months. So clearly a high percentage of patients with a recurrence. Local only was very rare, mostly was regional and distant. And residual disease is quite common in patients that have had incidental gallbladder cancer. So this is a study that Gene did looking at 116 patients who had prior non-curative cholecystectomy. The T1B group, the group that we think is very early stage and can do so well, a third of those patients had residual disease. T2 patients, half those patients had residual disease. And by the time you get to T3 patients, 70% have residual disease. So clearly high risk of residual disease after the incidental gallbladder cancer has been removed with a cholecystectomy. And the problem is residual disease is associated with poor outcomes. This is part of the study Gene did looking at residual disease after re-resection. So over here, this first curve is patients who had no residual disease, their survival was much higher than the patients who had residual disease. So clearly biologically, there's something very bad, strong association with poor survival if there's residual disease. And that's at any site. Now, when we broke it down to no residual disease versus local, regional, distant, or even local, granted these numbers start to get small here, but still didn't matter where the residual disease was associated with poor outcome. To the point where if you were T3 N0 and had no residual disease, so the stage you were from your incidental gallbladder cancer was your permanent stage, that was associated with a better survival than patients that went back to the operating room, say they were T1B or T2 and found to have residual disease in the gallbladder. Those patients associated with very poor survival. So there's something biologically about having residual disease in your liver or nodes that is associated with very poor survival. We also do have evidence for chemotherapy treatment. The ABC02 trial randomized 410 patients to gemcitabine and cisplatin versus gem alone. Now, this was a heterogeneous study with gallbladder, ampullary, and biliary tumors, but the addition of cisplatin improved outcome with overall survival of 11.7 months versus 8.1 months. Then there was John Primrose's BILCAP trial. This was 447 patients with resected cholangiocarcinoma or gallbladder cancer, randomized to capecitabine or observation over a 2006 to 2014 year period. And only 20% were gallbladder cancer, but that's unfortunately what you get with these trials. It's just so hard to accrue to them. And overall survival per protocol was 53 months capecitabine versus 36 months observation. So we have chemo agents that we know can work in this setting of advanced disease in gallbladder cancer. And we also can identify high-risk groups. So this is a study that we did looking back over a 20-year period at 254 patients with incidental gallbladder cancer. 74% underwent re-resection. And if you look at survival, T3, odds ratio 30 on univariate, 22 on multivariate, significantly associated with poor survival. T2, still significant, not as strong as T3. And when we looked at differentiation, poorly differentiated, significant association with poor survival on multivariate analysis, as was moderately differentiated, which did not reach statistical significance. Lymphovascular invasion, margins, perineural invasion, and perforation weren't significant on multivariate analysis, so I'm not showing that here. But if you look at this, it's T3 and T2 patients and poorly differentiated tumors clearly associated with more aggressive disease. So you start to think that maybe we could pick out patients who really have a very high chance of progressing and would be good to put on neoadjuvant chemotherapy to avoid an operation that really can't help a patient. So Shisher Maithel, who I trained with at Sloan Kettering, is now at Emory, has put together a trial that we've just opened here. We haven't even accrued our first patient, just opened a week ago. This is to determine if preoperative GemCis in the treatment arm, given prior to reoperation for incidental gallbladder cancer and postoperative capecitabine, is associated with improved survival at 3 years as the primary endpoint, and improved recurrence-free survival at 1 year as a secondary endpoint, and higher resectability as another secondary endpoint. And this is compared to upfront surgery followed by postoperative capecitabine, the control arm. So here's the schema. Patients diagnosed with incidental gallbladder cancer, they get baseline imaging, determined eligibility, they get a pathologic review, determine eligibility, and if they're eligible for enrollment, they're then randomized to surgery up front, and this is the control arm, or GemCis 3-week cycle times 4 cycles, and that's the treatment arm. If they get surgery, then they have their operation, and if they're eligible for it, and then they have staging laparoscopy followed by re-resection of liver and portal nodes. If they have GemCis, they're restaged with imaging, and after they complete chemo, if they're eligible for reoperation, they get staging laparoscopy and again the operation. And then they get restaging after the operation and get capecitabine for 6 months and then have follow-up built in. So this is a trial that is starting in the US, but I know is global in focus. So I'm hoping that this has or will make it to Chile, because I suspect this trial will rely on patients from Chile and probably India in order to meet its accrual. Now, we are doing more and more of these cases minimally invasive. So, but is there a role for diagnostic laparoscopy? Well, when we looked in 2011 at our incidental gallbladder cancer patients, we looked at who got laparoscopy and who got just a laparotomy. And the laparoscopy patients, we found only 2 had positive findings of carcinomatosis, whereas 8 of the 46 who had laparoscopy There were negative findings on laparoscopy, but positive findings once the laparotomy was performed. So this diagnosis required a laparotomy. But when we looked at which patients there was the highest yield, it was really the T3 patients. So I think if you are going back to do the liver and portal node dissection, then it is important to use diagnostic laparoscopy, at least in stage 3 patients, or if there's a question on a scan of some peritoneal disease. But as I said, more and more we're doing these minimally invasive. I think it's an ideal case to go back and whether laparoscopically or robotically do the liver resection and portal node dissection. Importantly, there really is not a role for port site resection. This is a patient who had a re-resection and resection of all the port sites, incredibly morbid, very high hernia rate. And when we looked, Ajay Maker, when we trained together at Sloan Kettering, he did a study looking at port site resection and found that port sites resected versus not resected, survival was the same in both overall survival and recurrence-free survival. And there were 13 patients with port site disease, which is 19%, all in T2, T3 disease, but all of them also had generalized peritoneal disease. So this was just a harbinger, a sign of such high risk peritoneum, not an isolated metastasis where removing it would have any beneficial effect to the patient. And the lymph node metastasis rate is important to think about. It's why it's important to do an extensive regional lymphadenectomy for appropriate staging. Very rare with T1A, which is why most of us agree that those patients don't need to have a re-resection, but over 10% with T1B, 30% with T2, and almost 50% with T3. And when we looked at the lymph node yields, higher lymph node yields were associated with improved survival. This is a study looking at 122 patients who underwent resection. The median number of nodes examined was 3, and the survival for N0 patients with more than 6 lymph nodes examined was significantly longer than N0 patients with less than 6 lymph nodes, suggesting that there is stage migration when you have less than 6 and a risk for understaging patients. So the goal is 6 or more. The extent of liver resection has also changed over time. It's now extremely rare to do an extended right hepatectomy. 15, 20 years ago, this was the majority of gallbladder cancer reoperations. Now it's really just segment 4B and 5, unless an obvious reason that the patient needs to have an extended liver resection. When we compared the differences in survival between those who did not and did get a major hepatectomy, there was no association with survival with bile duct resection and just increased morbidity. So that's only really done with a positive margin at the cystic duct. And this has been found in multiple studies. So I think that has put to rest the idea that a major hepatectomy is mandatory. So in summary, I think it's important with incidental gallbladder cancer to begin with restaging with a high quality CT scan. Important to review the pathology and to consider neoadjuvant chemotherapy and time for high-risk patients. Laparoscopy for diagnosis and MIS re-resection can be used to manage patients. I don't think there's a role for resecting port sites, and major hepatectomy and bile duct resection only when required. Thank you very much. Again, I really appreciate the offer and hope to see you in Chile in person sometime soon. Thanks.